Hi, this is Dr. Bhargava. I have several interesting body cases to share with you in this video. This is our first patient. They were suspected of having a bladder rupture and a CT cystogram was performed. And so contrast was instilled through the Foley catheter into their urinary bladder and a CT scan was performed. And on this slide, we have several images from the CT scan showing contrast extravasation to the intraperitoneal compartment around the liver. Also showing this defect in the bladder wall from where the contrast is leaking. Also on the sagittal image, we see the defect in the superior wall of the urinary bladder. Also seen here on this coronal image. The other interesting finding is that the bulb of the Foley catheter appears too inferior at the level of the pubic symphysis, and on the sagittal view we find that the bulb of the Foley is not in the urinary bladder but it's in the prostatic urethra. So that's not the right location for where this bulb should be. It should be inside the urinary bladder. So this is a good example of intraperitoneal rupture of the urinary bladder and malpositioned Foley catheter bulb. This is our next patient. She is a 93-year-old woman who presented with abdominal pain, and incidentally seen on her images was a focus of intussusception. We see that there is a loop of bowel inside another loop of bowel, and this intussusception involves the transverse colon. We can see the rest of the transverse colon going towards the splenic flexure in that direction, and this is the axial appearance of the colocolonic intussusception. There is no evidence of bowel obstruction, so this intussusception is likely incidental finding for this patient and not the cause of her abdominal pain. This is our next patient who presented for a FDG PET-CT scan and had history of breast cancer. On this rotating image, we find that there is recurrence in the region of the axilla, and on the fused images, we find that they have a left breast implant, a recurrence superficial to the implant, and metastatic left axillary lymphadenopathy. On the images of their abdomen and pelvis, there is free air, and there is diverticulitis and a perforated diverticular abscess that was picked up on a FDG PET-CT scan. So the patient was then admitted and treated for their complicated diverticulitis. This is our next patient that had prior surgery and a colostomy seen in the left side of the abdomen, and they've developed a complication where the loop that is supposed to open in the abdominal wall has prolapsed outside the abdominal wall, and so this is a loop of bowel with surrounding fat that has prolapsed outside their abdomen. It's not fixed to the abdominal wall anymore and needs to be surgically corrected. Next patient has this plain film, and this was acquired after a Dobhoff tube placement, and we can see that the tip of the Dobhoff tube is in the stomach, but as we look at the rest of the chest, we find that the tube is looping inside the esophagus. So this is a malpositioned Dobhoff tube and it needs to be corrected. This is our next patient. We have two images, plain films of the abdomen and pelvis. The bowel gas pattern is non-obstructive. There is gaseous distension of small and large bowel loops. The interesting finding is right here. There is air in the abdominal wall or subcutaneous emphysema, also seen here. And so when a finding like this is seen, it needs to be further evaluated with a CT scan or correlated with patient's history of surgery or intervention. This is a companion case where we are seeing a linear lucency which is symmetric on both sides, and this is subcutaneous fat that is seen just deep to the abdominal wall musculature and superficial to the abdominal content. And so remember, there can be abdominal wall emphysema or soft tissue emphysema, and then we don't want to confuse that with the layer of fat that is in between the abdominal wall and the intra-abdominal contents. This is our next patient, and this was an incidental finding on their CT where we see this focus of air extending into the chest wall, and it is lined by pleura, and so that would make this a herniated pneumothorax. Our next patient underwent a sniff test to evaluate the integrity and movement of the diaphragm, and so we acquired two images, a chest x-ray with inspiration and another chest x-ray with expiration. We find that during inspiration the right hemidiaphragm moves down compared to expiration, and then there is no movement seen on the left side, and so this raises the possibility that there is left-sided diaphragmatic paralysis, and this is most likely secondary to their prior open heart surgery, the coronary artery bypass grafting, and these are two views from their CT showing an elevated appearance or an elevation of the left hemidiaphragm, and the diaphragm itself is intact and there are no defects seen in the diaphragm or any herniation of abdominal contents into the chest. And so remember that diaphragmatic paralysis can be seen very frequently with patients who have had prior CABG, and it can be easily diagnosed by doing a sniff test where we ask the patient to take a deep breath, get a chest x-ray, and then we ask the patient to exhale and get another chest x-ray and look for motion or movement of the diaphragm on each side. This is our next patient. We performed a technetium-99m sestamibi parathyroid scan, and we acquired early images which show increased uptake in both lobes of thyroid, although asymmetric, with increased uptake on the left compared to the right. And then on the delayed images, we see washout of activity from the thyroid, and if there is persistent focal uptake like we see here in the left lobe of the thyroid, then this could be from a parathyroid adenoma. This is the ultrasound images from this patient, and this is the left lobe of the thyroid, and posterior to the inferior pole of the left lobe of the thyroid, we see this 2.4 by 0.5 cm hypoechoic focus with internal vascularity consistent with the parathyroid adenoma. A companion case showing again early uptake in the parathyroid and the thyroid on a sestamibi scan, and on the late images the uptake in the thyroid washes out, and this persistent focal uptake near the superior pole of the left lobe of thyroid is a parathyroid adenoma. And this is the corresponding ultrasound image showing this hypoechoic vascular focus posterior to the superior pole of the left lobe of thyroid. This is our next patient who presented with a left lower quadrant abdominal pain, and diverticulitis is a common cause of this abnormality, but in this patient we see fat stranding which is loculated abutting the colon with a central linear density which is the thrombosed vein, and all of these findings are characteristic of epiploic appendagitis, not to be confused with diverticulitis. This is our next patient, and they had a history of neuroendocrine tumor, and we performed a dotatate PET CT. On this rotating image, we see physiologic distribution of the tracer and a focus of increased uptake in the liver, which is consistent with neuroendocrine tumor metastasis, which is seen right here. It is slightly hyperdense on the CT. This CT is without contrast, and it's a low-dose CT for anatomical localization and attenuation correction. The focus is hyperdense because of hepatic steatosis, making the rest of the liver dark. There is this focal uptake suggesting that this is neuroendocrine tumor metastasis. The interesting finding is right here in the uterus, there is diffuse increased uptake. Also seen here, the uterus is enlarged showing diffuse increased uptake. This was evaluated further. This patient is postmenopausal. On their CT scan, there is endometrial thickening, and on the MRI, we see high T2 signal in this endometrial thickening. This turned out to be an incidental endometrial cancer picked up on a dotatate PET CT in a patient being evaluated for neuroendocrine tumor. This is our next patient. We performed a modified barium swallow. The several findings that we see here are there is a cricopharyngeal bar seen on these two images. There is reflux of contrast into their nasopharynx that we see right here. There is contrast going above the palate, and this patient is also edentulous. We don't see any teeth in their jaw, and there is also a tiny esophageal web that is seen anterior to this cricopharyngeal bar. This is our next patient, and they presented for evaluation of an ovarian cyst, and this is a cystic structure that we see in their left ovary on the long axis view, and inside this we have this irregular heterogeneous echogenicity focus with no internal vascularity, and so this is the characteristic appearance of a retracted clot inside a hemorrhagic cyst. And so when we see a hemorrhagic cyst, we follow up and we do a study in 6 to 8 weeks. Most of the times these cysts completely resolve. This is our next patient. We performed a MRI of the pelvis for abdominal pain, and we found this large complex cystic focus in the pelvis. This has a thick wall. This wall shows enhancement, and there's also a lot of surrounding enhancement, and so that would make this a tubo-ovarian abscess. There are some other findings in this patient. They have ovarian cyst or a hemorrhagic cyst on the right side, seen here as high signal on T1 weighted images, and these are post-contrast images. The uterus is displaced to one side that we see here with the endometrium. And so the diagnosis here is a tubo-ovarian abscess. This is our next patient, a companion case with MRI images from the pelvis. This is the endometrium. The uterus itself is enlarged, and we see these tiny hyper intense foci consistent with adenomyosis on the T2 weighted images. They also have a focus in the pelvis which is T1 bright, and this is an endometrioma, and it does not show any internal enhancement. This enhancement is seen in the enlarged uterus. They also have a ovarian follicle on the right side, which is seen right here, and it shows low signal on T1 and some peripheral enhancement. So multiple findings suggestive of endometrioma, adenomyosis, and a developing follicle on the right side. This is our next patient. The coronal T2 weighted image shows a tumor in the liver with a central scar. We see the same thing here on the axial T2 weighted image. On contrast enhanced images, on the arterial phase, we see minimal peripheral enhancement. On the portal venous phase, we see more enhancement peripherally, and it seems, looking at the delayed images, that enhancement is proceeding from outside to inside in a centripetal fashion, suggestive of a hemangioma. So this is a good example of a hemangioma with a central scar. This next patient presented with severe constipation, and on the CT scan we see that the rectum is markedly distended and the sigmoid is distended too. The findings are best seen on this sagittal image where there is marked distension of the sigmoid and rectum. It's filled with stools. There is circumferential mural thickening, and so the findings are consistent with severe constipation, fecal impaction, and stercoral colitis. Next patient had a modified barium swallow to evaluate for a leak after surgery. We can see the surgical clips from their prior surgery, and on this view we see that the column of contrast is right here going down the esophagus, but there is contrast extravasation to the right side, suggesting a post-operative contrast leak. There is an NG tube in place as well. This is our next patient with a modified barium swallow showing this outpouching from their esophagus, seen here on the frontal image. on the oblique image and also on the lateral image. And so something like this is a large esophageal diverticulum arising from the esophagus and going anteriorly towards one side. Thank you for watching.